Yeah, your introduction. I'm going to start the recording. And I'm really excited to introduce our speaker today, Dr. Rima McLeod. So Dr. McLeod is the medical director of Toxoplasmosis Center and professor of ophthalmology and visual science and pediatrics with infectious diseases in the College and School of Medicine at the University of Chicago in Chicago, Illinois. She's internationally recognized for her expertise and extensive pioneering basic science, translational, and clinical research on toxoplasmosis. And she specializes in the comprehensive care of congenital toxoplasmosis and other Toxoplasma gondii infections. She leads investigative studies designed to ultimately develop more effective screening, detection, prevention, and treatment strategies for toxo. Her research examines multiple aspects of the disease, including genetic factors, immune response, vulnerable populations, such as pregnant women and newborns. She's been funded by NIH Foundation grants and foundations such as the Thrasher Children's Charity and others. She earned her medical degree from the University of San Francisco School of Medicine, and she completed her internship at the Hospital of the University of Pennsylvania, included her residency at the University of Pennsylvania and the University of San Francisco. And she completed her fellowship training in infectious diseases at Stanford. And after fellowship, she joined the faculty at Michael Reese Hospital and the University of Chicago. So we're really excited for her to show us this presentation today. As a reminder, we'll allow some time for questions at the end. So if questions come up, please enter them into the chat or unmute yourself at the end, and we will be happy to have a lively discussion. And with that, I will turn it over to Dr. McLeod.
Thank you very much. I'm delighted to be able to be here and talking with you about understanding and eliminating toxoplasmosis. I wanted to present these disclosures. And by way of background, Toxoplasma, the parasite, is a member of the apicomplexan parasite family, and it's descended from an ancient ancestor of Copodelia, which you can see here, which attaches to cells, host cells, and ingests their content. This shows the ultrastructure with a conoid of microtubules, secretory organelles called rock trees, dense granules that establish the parasitophorous vacuole, and an unusual algal endosymbiont that has transferred its nucleus to the host, to the nucleus of the parasite, and then sends enzymes back into this sac of enzymes, making unique vulnerabilities for the parasite. Toxoplasma exists as a tachyzoite growing fast, a slow-growing encysted organism. When cats eat cysts in meat or oocysts excreted by other cats, they excrete up to 5 million oocysts for a period of several weeks, and they're highly infectious and long-lived. This phase is untreatable at present, and hypersensitivity and toxicity and some delays hamper care for active infection. This shows you the parasite as it comes to invade a host cell and invading a host cell. This is a tachyzoite. Bradyzoites do the same. Parasites exist as slow-growing bradyzoites in cysts, and they can be accessed by small molecules that have transductive peptides attached to them, and here you can see a fleur inside the bradyzoite. In addition, when G1 lengthens and the parasite gets stuck in G1, it can't pass a checkpoint that it needs to become a tachyzoite, and it looks very much like transcriptomically like malaria hypnozoites that you can see here in a comparison with Peace and Mowgli. The cat form starts as sporozoites or bradyzoites invading and then becoming schizonts, then merozoites, then female gametes and male gametes, and ultimately forming a zygote, being excreted as an oocyst and sporulating after several days in the soil. People acquire the infection by ingesting oocysts excreted by cats, or ingesting meat that's not cooked to well done, or transplacentally when the mother has a primary infection. That can come via leukocyte transfusion, organ transplant, laboratory accident, but that's uncommon. These are different ways that the parasite is in the environment, and I'll come back to that. Postnatally acquired toxoplasma is both endemic and epidemic, with epidemics occurring in large numbers along the Panama Canal, in a riding stable in Atlanta, from the reservoir up above Victoria, Canada, causing lymphadenopathy, retinal disease, brain disease. Epidemics are occurring in this country associated with the ingestion of venison tartare, are not cooked well, especially from white-tailed deer. These are a series of cases. The first two are associated with the consumption of venison tartare with effect on the fetus and devastating infection. Mom was asymptomatic. Dad had persistent lymphadenopathy for about a year. This grandmother with lymphadenopathy was quite ill. Her daughter was ill for about a week, as was the 1-year-old who ate the rare venison. This is again a case where the pregnant woman and the congenitally infected baby were the sentinels, and all 8 children in the family were acutely infected from a sandbox or possibly from gardening. And there are epidemics of retinitis and congenital infection throughout Brazil and Colombia. In this case, it was due to contamination of the headwaters of the Quindío River outside of Armenia, Colombia. J.P. Dubey wrote a very nice summary listed here that describes the epidemics over the last 5 decades, both due to undercooked meat and to oocysts. We were in Colombia and Panama, where we've been working, and there are epidemics, again, from the Quindío River. People who drink bottled water remain seronegative, but there are epidemics of congenital infection and also of eye disease. And in Panama, moving from west to east, you can see that the prevalence goes up, and certain populations, like the poor population in Kurundu, has a very high prevalence compared to the 50% in the rest of the country. Other examples of the environmental contamination by oocysts or consumption of rare meat are a mini epidemic on Baffin Island among indigenous populations who consume migratory animals like caribou, with several severely affected babies. In California, near Pajaro Dunes, Moss Landing, and Morro Bay, sea otters are dying from consuming mussels, where the runoff comes from the soil. The mussels concentrate the oocysts, and the sea otters die. In Hawaii, on Kauai, and in Oahu, there are areas where monk seals are dying, again associated with rainwater overflowing sewers and going into the ocean. The Chesapeake Bay has a substantial amount of toxo-DNA in the sampling from the EPA, and the Lancaster Amish have a high prevalence of infection due to cats in the barns, sandboxes, gardens. Our mothers, in a cohort of 250 families started in 1981 that I'll tell you about in a minute, 78% of them had antibody to the cat form, the sporozoite form, but virtually none had a real cat exposure. This is the cat you don't see. It's the cat in your garden, or in the water that you drink, or on the food. and it clusters in families. This is a case recently from Sandusky, Ohio, where the involved infant and the mom were the sentinels, and the sibling, when looked at, was also infected. This shows the prevalence in different countries in the world, dark red being the most prevalent, red moving to green and yellow. And the areas where their arrows are areas we've worked and confirmed that prevalence with colleagues, and that's of encysted organisms making antibody. This is a large data analysis of 150 million insured lives using CPT codes in the United States. And again, you can see it's patchy and areas of prevalence differ, and they are similar to those areas that we see with children. And there are also areas where population is high. Importance: 1.9 million new cases of congenital toxo globally annually, causing 12 million disability adjusted life years back in 2012 to 2013 and more now. This parasite is in the brain of 3 billion people infected worldwide across lifetimes, and it's costly. USA varies by region. France is decreasing in prevalence. Morocco, Colombia, Panama, around 50% of women of childbearing age. Pathogenesis is fairly straightforward, with ingestion, transport across the intestine, dissemination lymphohematogenously with a competent immune response. It's contained. And pathology is mainly necrosis, inflammation, and acute infection. I'll come back to lymph nodes and just emphasize that for congenitally infected babies, periaqueductal and periventricular vasculitis is a hallmark and something unique. Diagnosis is made by isolation of the parasite, histology, but PCR, serology. And as you know, IgM and AGA go up, but it's important to note when you think about pregnant women especially, that IgM can stay up for longer periods of time. Avidity for IgG goes up around 12 to 14 weeks, so that can be helpful in timing infection, but a low avidity can persist indefinitely. Differential agglutination with acetone or formalin-fixed parasites can date the infection to the preceding 9 months or longer, which can be helpful when thinking about pregnant women. Osler said, think about who gets the disease, and toxo is really that. It's a mimic of many illnesses, and it's different depending on who has it. Acquired postnatally, acute, mild, severe, ocular, chronic, active, central nervous system, immune compromised, immune susceptible by virtue of genetics, gestational infection, congenital are the categories. Indication for therapy is if somebody has significant damage to vital organs, active chorioretinitis, immunocompromised people improve with treatment, pregnant women, congenital infection. In the immunocompetent person, the signs and symptoms are listed here. Most often it's asymptomatic or unrecognized. In the Atlanta epidemic, 32 of the people were sick enough to seek care from an internist, but the diagnosis was made only for 5. The lymph node histopathology, as in this patient, is characteristic. It can involve cervical pectoral nodes mimicking breast malignancy, epitrochlear nodes, periappendiceal nodes mimicking appendicitis. This surgeon didn't wait for serologies, which would have made it not necessary to do a biopsy, but what they saw was these epithelioid histiocytes and monocytoid cells encroaching and blurring the margins of germinal centers, which is a fairly pathognomonic histopathology. This is an active eye lesion. This is a boy, a young man, who was with his college class tracking cats using cat scat as the way to track them. He came back with blurring of the vision in his left eye with this lesion. He was treated promptly, and you can see complete resolution. This lady, this 40-year-old woman, was bird watching parrots in the Amazon jungles of Peru, and she developed fever and pneumonia and a large liver and big spleen and severe active chorioretinitis with a prolonged illness. She had acute infection, excuse me, serologically. She was treated with very slow resolution. This type of infection is seen particularly in Guyana, French Guiana, in the Brazilian Amazonian tributaries with deaths and epidemics. From chronic infection from the cyst, parasite can recrudesce and cause severe eye disease, like in this immunocompromised person, or in this person with HIV/AIDS, with this area of his brain being the only normal part of the brain, or in this heart transplant recipient who got heart from someone in a motorcycle accident, and then developed these brain abscesses. Aspiration showed the parasite. He was treated and he completely resolved. It took about 6 months for his focal neurologic findings, hemiparesis, to resolve. A few other additional recent cases were an older man from London with DeGeorge syndrome, a 40-year-old man with extensive brain involvement and pneumonia turned out to have CVID, a 7-year-old child who failed Bactrim treatment for her pneumonia and encephalitis, but responded to pyrimethamine and sulfa. And I know that I heard a question about Bactrim treatment, and we'll come back to that later. A teenager with a stem cell transplant, a 60-year-old man with hematologic malignancy in Kentucky with extensive brain disease. This is a beautiful paper by Karanovic and Natarangelo and Michael Grieg and others from NIH of a case of a baby with brain disease and disseminated disease with a mutation in a PI3 kinase that involves phosphorylation of FOXO1P, and the mother had disseminated or extensive lymphadenitis, and this mutation leads to a primary immune deficiency, and they had a very nice summary of primary immune deficiencies in this paper as well. Immunocompromised, chronically infected pregnant women should be treated. Untreated and treated congenital toxoplasmosis. What have we learned about this? Well, it occurs when the mom gets it while she's pregnant and transmits to the fetus. It can occur anytime during the 9 months of pregnancy. It transmits less frequently early in the pregnancy, but disease is more severe. In mid-gestation, transmission is in between, and disease is intermediate, can be quite severe. And at the end of gestation, transmission is almost 99%, but babies look normal. This is the baby you take home, you think is normal. We don't pay any attention to, looked at carefully, may have eye disease, but such children don't remain normal. Virtually all of them have sequelae. Eichenwald, a long, long time ago, looked at sequelae for children who were symptomatic with either neurologic or generalized disease. And you can see that the consequences are pretty devastating for brain and eye for all those children. Wilson and Stagno and Alford, Remington and Copy looked at mild children, like the child I showed you, infected late in gestation. These kids don't stay normal. Virtually all of them have eye disease by the time they're teenagers, including loss of sight and severe permanent neurologic sequelae and sequentially lower IQ scores. This is not a disease without consequence. This infant was born to a mother who had fever and positive toxoserologies in late gestation. The infant looked normal at birth. In the first months of life, she developed a sunset sign and bulging anterior fontanelle. Treatment was begun with an older French regimen. This happened in 1981. And she had a ventricular peritoneal shunt, was treated, and she's done well. She's has some college and a full family life. This shows her sunset sign and bulging anterior fontanelle and the development of hydrocephalus that responded to shunt with normal cortex. And she was a little kid who started this all. So we talked with Hitchings and Elian, and they told me that if we treated children like we had learned we could do for immunocompromised people, that we would have all aplastic and kids with cancers, and we would do something terrible. And we knew we were in a rock and a hard place in terms of what to do in terms of treatment. So we very bravely, really the parents of children very bravely decided to try. And so we did. We made a study group, which continues today, and it really is all of these people who are responsible for the NCCTS. And we wanted to figure out how to treat this. And we looked at children diagnosed before and at birth, treated during the first year of life, who missed being treated and came to us after a year. We looked at feasibility, safety, reasonable approach, natural history, and then did essentially a phase 1 clinical trial, um, and then followed children at regular intervals in person with the study group to contrast treatment or no treatment or treatment with a higher and lower dose ultimately. These are findings in the children, so you can see that they have systemic findings and neurologic findings. And we've decided to make a suspension of pyrimethamine and sulfa because they're only pills, and did essentially a pharmacokinetic study at terminal phase kinetics, figured out the levels of pyrimethamine and found that those levels could treat the parasite in tissue culture and completely clear it, and the levels achieved in CSF as well. And then we followed the first 14 children, and here I'll tell you more about this little girl. You've heard about this child and about these children, but active form of infection can be treated. That's true in tissue culture in mice and those with ocular disease, and in the fetus and newborn infant and throughout the first year of life. And current treatments after birth can result in good outcomes, but can be less than ideal. And sometimes treatments are started too late. And 70% of the first 14 children walked and talked and heard and didn't look like the Eichenwald children at all, and eye lesions resolved. We therefore, 2 children took a higher dose, not intentionally, and NIH advised us to make a randomized control trial, and Paul Meyer helped us, of Meyer-Kaplan, and these were our pre-specified endpoints and our detectable relative efficacy, and we randomized to the higher or lower dose, meaning either 2 months or 6 months of daily pyrimethamine. And then families started to come. We didn't solicit anybody, they just started to come. And what we found was these were sick children. They were diagnosed at birth. They had systemic findings equivalent to the green bars in the Eichenwald studies. And they had brain disease equivalent to the Eichenwald children. These children in the United States at the present time were sick. And they were largely severe children, but some none and mild children appeared, and they were included. What we found in summary is that what historically was seen are the tops of the histogram bars in blue for severe and mildly involved children. And what we found was what happened in red or in pink in those categories. Of this, the children who came at a year, we could see peaks in recurrent chorioretinitis at school age entry. In adolescence, we saw it in the treated children, but less. The children who came later looked like somebody threw a paintball at the eye with multiple lesions. The children who were treated prenatally or at birth had sometimes large single lesions, bigger, but they didn't make the satelliting in as much. Looking at a Kaplan-Meier analysis for the 2 treatment regimens, you can see they don't differ substantially. And we set this up not expecting for one to fail. We didn't make a placebo group for equipoise, and we chose a lower dose that we expected to succeed. We encountered reversible neutropenia that required temporary withholding of medicine, and we found that we didn't eradicate encysted parasites. There was a serologic rebound at a year, but we had no cancer. We had no aplasia. Everybody got through the year, and these were functional children. This is eye disease in children with congenital toxoplasmosis. I sent an atlas to Elise also, so you could see some more pictures, but this is an old scar. This is an active reactivated lesion with haziness over it. This is sharply demarcated. This is what this looks like in fetal tissue, and you can see the parasite hangs out in cysts and has bradyzoites, and then there's necrosis and inflammation. This 17-year-old was diagnosed at 3 weeks of age when she rolled off the bed, had a brain CT scan with calcifications. They recognized they missed her infection when she had rule-up sepsis and thrombocytopenia at birth. Her lesion reactivated, she was treated, and she's done well. Here you can see the large lesion next to the optic disc, resolution with treatment over time, and just a little scar left. Similarly, on the OCT, where you see the layers of the retina, you can see the fluid and inflammation between those layers, and then the resolution with treatment. Choroidal neovascular membranes occur when vessels invade into the retina as part of the acute infection. The parasite turns on HIF1 alpha, which turns on VEGF and induces this finding with bleeding. And this 30-year-old father farmer came with abrupt loss of vision and this kind of bleeding with a suggestion of a lesion underneath. It looked like adult macular degeneration to us. And he was treated with anti-VEGF and toxomeds, and you can see the resolution of the lesion, leaving a little scar, and you can see the bleeding and activity and the fluid and seeing it go away. This was a little boy who ate some sand at 6 months of age when his family was vacationing in Brazil. He came with an active choroidal neovascular membrane with bleeding, and you can see it shrink with treatment and the fluid resolve. This is the pathophysiology, the invasion of blood vessels. This is the treatment algorithm where you have a choroidal neovascular membrane and active disease. You treat with VEGF, anti-VEGF, and with toxoplasma medication. This is a little girl who was one of the first children we treated. She was placed for adoption, but nobody would take her when they did a CT scan and they saw this mottled looking brain, a little bit of dilatation, some calcifications. 2 nurses in the NICU adopted her. You see the calcification got smaller, her brain grew. She's a happy, active 3-year-old. One thing that surprised us was the calcifications actually went away. This is birth, this is a year. This is birth, this is a year. This is birth, this is a year. And I'd always thought of calcification like bone, but they seem to resorb. This is a child with hydrocephalus, responds to shunting. Hydrocephalus is not always without hope for normal functioning. This little boy had hydrocephalus and acute congenital toxo, and the neurosurgeon where he lived wouldn't shunt him. He told the family they should just assume that he was going to get sick and die. His parents came with him to Chicago. He was shunted by a different neurosurgeon who had trained with one of our neurosurgeons, and he's a happy little guy now, able to push all his siblings' buttons. They encouraged us to put together the 60 patients that we had in this category that told us that you could shunt with aqueductal obstruction, with obstruction of the foramen of Monroe, or this fibrotic type of hydrocephalus and get good results. And the faster you shunt, just as the faster you treat this infection, the better the outcomes. This infant was born by the side of the road during the pandemic surge without prenatal care, with a lot of cats around in the NICU for a month, thrombocytopenic, rule out sepsis, no toxoserologies. A family came to adopt the baby in the bed nearby. They adopted him instead when the family kept the first baby. He wasn't moving his left leg. He had a hernia. They thought that was why. And then they noticed he had hydrocephalus. It worsened, spinal cord lesions, a CSF protein of 1 gram per deciliter, which is pathognomonic. And serology confirmed his congenital toxoplasmosis. 3 Chicago neurosurgeons refused to shunt him, but another did. And he was treated, and he has had expansion of cortex with steady developmental progress, happy in a warm, supportive family who cherish him and he adores. And here you can see him. You can see the progression of his hydrocephalus, his spinal cord lesions, and crossing percentiles, and then expansion of cortex. This little boy was not so fortunate in the Central Valley of California. He came back to the ER with aseptic meningitis multiple times. They didn't diagnose him until quite late. He ultimately was shunted but has severe sequelae. And this little girl had a 3-month delay in shunting and I suggest you maybe look at her mother's testimony about screening. So in the US, treatment prevents disease and adverse outcomes. It's proven the earliest treatment, the best outcomes. It's made a cohort. We can ask what happens over time, and not all parasites are eliminated. I'm going to tell you a little bit about parasite genetics and prematurity and severity, and I'm going to go quite quickly. So this is work that we did with Mike Grieg at NIH. He has a peptide ELISA that differentiates type 2, the European kind of toxo, from not 2, which was thought to be the South American type of toxo, although we have actually all kinds of toxo in the United States, type 2, non-2, wild animal kind of toxo, with a non-2, non-French kind of toxo more in the Gulf and along the West Coast and Hawaii. This non-2 toxo is associated more with rural locales and lower socioeconomic status and Latino ethnicity background, prematurity and severity. This doesn't pick up all the genetic variability in the parasite. The patterns of hydrocephalus are more often, but not exclusively, type 2 with obstruction of the aqueduct of Sylvius, with Foreman-Monroe sort of in between, and this fibrotic, non-obstructive is more non-type 2s. One thing we learned was that when children were treated in utero, they lost the association with prematurity and severity. And that same was true when we treated children postnatally. We didn't see a difference in the type of parasite response. Treatable regardless of genetic type of parasite. Untreated disease is a tragedy at this point. It's preventable and treatment works. So this just summarizes what I've told you with the statistics associated with it. And it's important to treat. The genetics are more polymorphic than 2 non-2, and Jeroen and Mike have expanded their peptide ELISA somewhat. I wanted to talk about the special problem of the pregnant woman. This lady diagnosed mid-gestation with random screening. When she asked, is the way not to do this? Screening pre-pregnancy and monthly, and treating the seroconverting woman to prevent infection in the baby is the way to do this. That's what they do in France. Diagnose mom, treat mom, diagnose fetus, treat fetus. Outcomes are better, and you can see the marked difference. There's decreased numbers of cases, decreased disease, decreased maternal child transmission. They're now using sparomycin in the first 12 weeks of pregnancy, but after that, sometimes they continue the sparomycin, sometimes they treat with pyrimethamine sulfa. We've begun to build programs in other countries and trying to do this also in the United States. It remains a glass half full and empty. Gestational screening to diagnose and treat really makes a difference, and doing that more rapidly to avoid illness like this poor little baby in Morocco. In Colombia, they've essentially eliminated severe disease and much of the maternal child transmission. And this now is mandatory in France, Austria, Colombia, Panama, Brazil. And we're working here. One of the things we've done is to look at cost-benefit analyses. Eileen Stillwagon and her husband, Larry Sowers, were the economists who worked on this. And they looked at Austria, where there is meticulous documentation of serology and a robust program. And what they found was that they reduced maternal to child transmission from 51 to 11%. And the numbers of cases from 78 per 10,000 to 1 per 10,000 by screening and treating without delay. And no children have the profound lifelong injuries we see here. They want to stop, but now they're recognizing that's a paradox, because if they stop, they'll go back to where we are in the United States. They've recognized that doing the right thing is also cheaper than neglect. The benefits are 14 times the program cost, and the cost of 1.9 euros is 0.003% of the Austrian budget, or 0.0006% of the Austrian GDP. In the United States, a cost-benefit analysis, if it's not inflated, for pills and medicines and screening, is $2.5 billion per year saved, estimated. We've worked on point of care testing, which is reliable in a variety of settings, inexpensive, adaptable to include tests for multiple diseases, and with spillover benefit. The idea is you screen pre-pregnancy, and monthly during pregnancy, you pick up the seroconverting patient. You find out who's infected before, they won't transmit, and you don't just randomly screen once later. This I'm going to show you a little bit about something we've been working on. There's also a nanogold test, which is highly sensitive and I'm promised will also be cheap. And multiplexable. Here you can see that you collect serum. It looks much like pregnancy test or now a COVID test. And you can see that it picked up all the types of parasites on sera, both in chronic and acute infection. And similarly with whole blood, with a finger stick to get rid of centrifuging. This now meets the WHO assured criteria for a perfect point of care test. This shows what it looks like to do it. It's read in 20 minutes. The cost is $4. And it can be done in multiple places in a jungle in Panama or Colombia. I want to tell you a little bit about genetics of the host of people and some things about resistance and susceptibility. I alluded to that with the Notarangelo paper. And essentially, we've worked with mice, then people, then back to mice again with candidate genes and using recombinant congenic mice, and then looking and documenting phenotypes and using the cohort. And these are just some of the susceptibility alleles which provide insight into the immune pathways that are protective. I wanted to tell you a little bit of how we've used those genetics and some genomics and omics and systems biology about what do they tell us about human disease. This is a parasite that 3 billion people carry, probably the most common parasite in the world. And what we found was that Toxoplasma modulates signature pathways of human epilepsy, neurodegeneration, and cancer. I'm going to go through this very, very quickly, but the paper is in scientific reports. And first we looked at the genes. The genes are expressed in the human brain. We looked at their upstream regulators. We looked at transcriptomics with primary brain human neuronal stem cells and the pathways that were perturbed. We looked at proteomics and we found again genes associated with Alzheimer's disease or neurologic disease like ataxia telangiectasia, Niemann-Pick, or Fragile X. With Lee Hood, who very generously let us test 3 pairs of children, we found that serum microRNAs that Toxo turned on in tissue culture and proteins of neurodegeneration during active disease are biomarkers of disease and pathogenesis and activity in pregnant women and in severity of illness in babies. This shows you the microRNA data and the protein data and the pairs of matched either twins or like children. This puts together the genes, the biomarkers, the transcriptomics, and the proteomics in a systems orbital analysis, looking at upstream regulators. This is a second set of cells and putting together 2 people's primary brain neuronal stem cells. And we could find the overlapping genes and the protein-protein interactions. This was kind of intriguing. You remember Toxo alters this odorant receptors, and a netylation, NET8, a ubiquitination gene, is central. But especially importantly, if you look at the pathways of the genes, These genes are associated with the toxoperturbs are associated with neurodegenerative diseases, Alzheimer's, tauopathies, amyloidosis, epilepsies, motor disease like Parkinson's disease, and this large group of malignancies. And if you look for phenotypic correlates in tissue culture here, you can see NF-kappa B is pretty central, and toxo changes whether it's in the nucleus. Here it's not in the adjacent uninfected cell, and it's in the nucleus across all three types of parasites. And similarly for dopamine and tyrosine hydroxylase. This is this parasite that grows as from Brazil, that grows as a cyst in tissue culture. And again, you can see, among many other things that I won't emphasize, the Alzheimer's genes and neurologic disease genes that the parasite perturbs. We think that when you have the right pathology mechanisms genetically, the right toxoplasma infection and amount, and CNS disease susceptibility, you come in the middle of this Venn diagram and get these other diseases. So what happens with chronic active infection in a congenitally infected person and those who acquire the infection postnatally? You'll read about all these things being associated with toxo, and there's more and more evidence that this isn't really bogus, which I thought for a long time. This is a billion brain parasite. What about mice and people? Well, in mice, it changes behavior. We documented that. You can see the inflammatory process adjacent to the hippocampus and the dentate gyrus, not in the controls. And more recently, if you treat mice, you can see these go away and the behavioral neurocognitive disorders go away. This is a lady who was cared for at NIH as a child. And she was given pyrimethamine sulfa. She stayed there for about 6 months, but then she got steroids, and then she got steroids with no antitoxo medicines, and it really harmed her eyes. You can see these immense scars, but she persisted, and she worked as a social worker, and you can see small calcifications, and then in her 40s, she developed additional lesions and T2 weighted abnormalities like we found in mice. And she developed spinal cord lesions and she couldn't walk anymore. She was treated, these went away, and she danced at her son's wedding when she was 49. This is a paper I think that's really important about the risk of dementia and a large data analysis in Taiwan just published recently. And you can see that there's difference for seropositive people versus seronegative people, and that if they were treated with sulfadiazine or clindamycin before, it abrogated that association. And we've seen something similar in terms of cognitive associations, and others have as well. So what can we do to make this better? How can we work toward making medicines that are better, that get to encysted organisms, get to the Achilles heels? Can we use antisense? How do we deliver them? How do we formulate them? This is just a snapshot of some recent work where the molecular target was identified in these parasites that grow as encysted organisms in neuronal stem cells and monomac cells. And then going from hit to lead over many years now. With cryo-EM, you can see a lead compound, JG21, in the binding pocket active site of cytochrome BQI. And when it's used in vitro and also for malaria, you can see efficacy, and you can see in vivo in mice, the untreated mice all get lots of luciferase parasite, and then they die, and the treated mice all survive, and the cysts go away 95% of the time. And we can formulate it as a single oral dose or 3 doses as a nanoformulation with Bob Prudhomme and Kurt Ristroff at Princeton, and we can clear the parasite and give into a mouse model of malaria, luciferase, untreated, treated, parasitemia, untreated, treated, death, untreated, treated. So it looks like it's heading toward being a medicine. We hope so. And this is really thanks to some wonderful people at Walter Reed and I'm not going to tell you a little tiny bit about delivery and prodrugs. To get to cysts, we can use a transductive peptide, carry a small molecule inside cyst, use a morpholino for antisense treatment, use that for target validation, and we hope ultimately to see that move to the clinic. In terms of vaccine, this is just a snapshot and it involves many people. I'm going to highlight the people at NIH who might be here and recognize themselves. Alan Shearer, Dragana, Riccardo Gazzanelli. And we can make a live vaccine that eliminates the parasite. And we can use an immunosense approach, identifying the peptides that bind to human MHC to make a vaccine for people. And epitope identify, use adjuvants, which are very powerful. And that immunosense approach has resulted in peptides plus the adjuvant being efficacious. And we can combine those together and it makes them better. And then we can put them into self-assembling nanoparticles. Dave Lennar, Walter Reed, and Pete Burkhardt was at UConn at the time. And then you can see the assembly of this coiled coil, and you can see it assemble like this and make nanoparticles and then given to mice. And it stays longer with an adjuvant in the lysosome. And here you can see the progression through that with prevention of infection. And one very exciting thing that we're just starting now with Didier Bedbetter is to try to put our identified antigens into his cationic lipid nanoparticle. In French zoos, monkeys, primates, newer primates that are very susceptible were all dying. I don't know exactly why. He began using his lysate in its cationic lipid, and you can see the deaths all stopped. And it actually worked as a therapeutic vaccine as well. And there's been no deaths since, and we're hoping we can not use a tissue culture lysate, but identified nanoparticles in an RNA we've also used in order to have something that's an immunosense vaccine. So prevention of infection and disease with gestational and newborn screening, education, care, prenatal and postnatal treatment and follow-up, medicines to cure, vaccines to prevent, and public health programs to make things better may make what this wonderful family said, that Toxo stole her daughter's full potential, and with the hope of current possibilities for screening, vaccination, and treatment, beautiful dreams might have become a reality for her. And that's what we've been trying to do. There's a lot of us here that I won't acknowledge, so there's time for questions. But thank you and questions.
Thanks, Dr. McLeod. That was a great whirlwind tour of all just a huge number of years of work. I guess while we're waiting for any questions to come into the chat, I wanted to start off with, obviously this is a bit of a problem in the Chagas world as well. What needs to happen to make this kind of screening in pregnancy standard of care?
Well, we're working on it. We have taken the point of care test. From the cost benefit analysis, we recognize that our hospital charging $650 a test and 10 tests in pregnancy were a problem. And so we worked with a small biotech and found out that what they had made was really good. And we've tested it now in over 3,000 people in 5 countries. And it's 100% sensitive and 100% specific with 99% confidence interval. And we adapted it to whole blood. We have one more test to see if the package insert that's made can actually teach doctors, nurses, and then it's ready for FDA clearance and CLIA waiver evaluation. When I presented to the Thrasher Foundation, we knew it was really good. And we had tested it, and the program officer told me, you can do this till the cows come home and it won't make any difference. get it through the FDA. And very naively, I said, oh, sure, yeah, I'll do that. That was now 2018. But they've been lovely to work with and they want to do it. It was set aside because of COVID and monkeypox and polio, and no devices are being considered. But we have this one last test to do. And if it works, we can go back and ask them to please look at it. Once it's available, then we're building a network. People call me from all over the country and we follow children, and everybody wants it. And so we initially went to the legislature with families because the families really pushed us. I'd never done anything like that. And the legislature said they wanted to do it. They were going to tell obstetricians what to do, and they were going to make a law, just like France and Panama and Colombia,
Yeah.
make a law. And that would be the end of it.
Mhm.
But, and because it was so compelling, the public health people were there, the obstetrical societies were there, the right to life people were there, and they all came up with different concerns at the end. And the right to life person said, oh, I see you're not trying to terminate pregnancies, you're trying to protect babies. Okay, we're fine. And the public health people said, do a cost benefit analysis and show us how to do this. And the obstetrical society came up and said, you're in a guild and you don't tell us what to do, you teach us how to do it right. And as it changes, we modify it. So I gave obstetrical grand rounds and I wrote and we published things, and the obstetricians love it. They love working with it. The patients want it. They want their husbands and friends to have it so they can be screened for eye disease. It's not reception here. In Colombia, it was a little harder, but it's really a matter of making it cheap. $4 instead of $650 a test, showing that it's cost efficacious and saves the country money and saves insurance and money, and making something people can do and learn from it and teach others and incorporate it in their own care. And the people who came up to me were correct. It's been a long haul for me, something that was not what I intended to do, but I can see the spillover benefit. And something like this could work easily for Chagas the same way. The principle of the test is simple. And if there's serum banks, it could be tested in the same way we did. And there's an algorithm for adapting it and really making a difference and getting rid of this in this country, like they have in Austria, like they have in France, like they have in Germany, like they have in Colombia, like they will in Panama. We can do it here too. And I hope we do. We'll see. I don't know. It's a road I've never walked down. I don't know. Just as I didn't start treating babies in the beginning, it just was a need. And so we hope we've done it.
While we're on the topic of screening, would you be able to comment a little bit about the quality of the existing commercial serology? My main experience with toxoplasma in pregnancy, as you've alluded to, are people that get tested for toxoplasma for one reason or another, either right during pregnancy, either they have, the obstetrician decides to do it because they have a cat, or they've just come back from travel, or they've had some sort of non-specific fever, the IgM comes back positive, and then we have this horrible waiting period to get the test results back from California, while we sort of figure out what the significance of the serology is.
I was going to show you cases like this 10 times over. I get at least 2 to 3 of them a week, and this will help it because this test is cheap. It's easy. Once it's approved or cleared, then people can use it. Clinical labs can use it. The obstetricians can use it. And that means they pick it up in the clinic. The false positives don't arrive at the lab. And when you get the false positives at the lab can test it. And then, although it's new, it's got, with false positives, we've looked at it now with about 120 sera. It doesn't have the false positives. In Marseille, there were a few from people with leishmania, but that's about it. In this country, we don't have any. Which means the clinical labs have a really easy tool that they can use to test, to see if the big machine tests have problems. And they do. some of them, 1 out of every 10, and that will completely destroy screening because you can't cope with that. It's hard, and the amount of anxiety and difficulty for pregnant women, and for you as the doctor helping them, this is the solution to that. The labs can use it, they can check it, they can say it's not, it's new, and you need to send it to a reference lab to check it. Um, and but they can check it it can be checked at the same time and say, well, it's highly unlikely, you have 100% chance of it not being real, or my goodness, it looks like it might be, you better be treated now while you wait for the 2 weeks to go to Palo Alto and pay $2,000 for the backup tests. So I have a paper ready to go that says exactly this. This is a new paradigm for us, and it solves that problem. And it's not good for pregnant women to be anxious for 2 weeks. Obstetricians won't screen if you've got a mess. When we were doing the clinical trial for the testing in the clinic, the first 6 people, we got 2 false positives with the biorad test that the FDA required for us. And the obstetricians, they looked at me and they said, what do you want us to do? And so we tried to re-standardize the machine in the clinical lab. We sent the samples off. And then we realized we'd made an algorithm because we knew the finger stick wasn't positive. And we knew that when we did it with sera, it wasn't positive. We knew we couldn't say, because the IRB wouldn't let us say, but we could say in a circumstance like that you don't need to worry, or this really looks real, we better treat you right away so your baby's okay. So you couldn't have primed me with a better question. And I am delighted you asked the question, and it's exactly right. And it's what happens day in and day out. And this is a solution.
That's great.
Thank you. So I'll send you the manuscript. It's ready to go.
Thank you.
I'll send out some of the
publication.
you had sent me. And I think we might have to go to a close at this. Well, we have 2 more minutes. I might just really quickly ask one quick question. What is the regimen you give if somebody truly can't take a sulfa drug, if there's a real contraindication there, for recurrent eye disease, for instance?
Right. Well, we always treat eye disease with pyrimethamine and sulfadiazine in the absence of hypersensitivity, like you're describing. We don't use Bactrim. Bactrim is suboptimal. The ratio of the trimethoprim and sulfamethoxazole are suboptimal, and the half-life of the trimethoprim is short compared to the pyrimethamine. We get Bactrim failures all the time, and lack of it as good resolution. And like the little girl with the stem cell transplant with brain disease and pneumonia, her parasitemia persisted until she was switched pyrimethamine and sulfadiazine. So that's just an aside early, and you can see it if you look at it in tissue culture. You can see that that's less good. We substitute azithromycin for the sulfonamide, which is usually where you have the hypersensitivity. The responses are slower, but it's good in tissue culture, it's good in animals, and it seems to work. And we've used that for suppression as well, without a clinical trial and without, it's anecdotal, but when people have had several episodes, one after the other, they have one non-seeing eye, we've used azithromycin as the substitute, and just standard doses. And we've done that for little children and older children and adults, and it seems to work. And we use that if we can't use the sulfadiazine, but we don't use Bactrim. We don't use it for suppression like Nusamblot did, because you sensitize people to the sulfa, and then when you really need it, you haven't got it. So we're careful with that. So it's an easy approach. And you comment that eye disease is so hard to treat. It's not so hard to treat. We don't have failures. It's hard to treat when you use the wrong medicines.
Yeah.
So I'll be very popular with that, but that's the way we do.
That's great to hear. Well, I think in the interest of time, it seems that we're coming to a close here, but thank you so much for your talk. Really appreciate it. And I'll be sending out some, all of the materials that you'd sent me to the rest of the group. Thank you.
Thank you so much for asking me, and I'm delighted to be able to talk about Toxo to people who will care about it. So that's really, really nice for me. Thank you. And nice
Thank
to meet you.
You
Okay.
too. All right, bye. What?